Cool, thanks, Mark. So welcome, everyone. I'm just going to share my screen. And as Mark said, if you can save questions till the chat at the end, I'm going to talk just for about 10 minutes with an overview. So let's share screen. Right, good. So as Mark mentioned, I took over as Diploma Director last March from Andy Logan, and I want to give you an idea of what's involved. She says, having not been able to turn the slide over already. Right, what is the hand diploma? So it's a course of study to build knowledge and confidence for life as a consultant hand surgeon, and it's aimed at senior trainees and young consultants. This is a taught course with a very structured programme and syllabus of learning, which is set by the BSSH Hand Diploma Committee and the University of Manchester, but the delivery of the education is local to you. There's a real emphasis on clinically relevant information, and we aim to examine at the level equivalent to a day one consultant hand surgeon. Now, I can't emphasise this last point enough, that this is not just another exam. The hand diploma, I still maintain, is the most useful thing I've done in my entire career. It's not just another exam, it's a lifestyle. No, it's pushing it a little bit far, but it's something that's been so useful for my whole career. So I found everything I learned for it was relevant, and the people that you meet, either as other candidates or as tutors and supervisors, are absolutely invaluable to your ongoing career. So I've met not only just friends and colleagues, but long-term mentors through this programme, and I cannot tell you how much I value that. So I wanted to mention quickly the hierarchy of learning, which is all a bit educational, but the 6 levels there: knowledge, understanding, application, analysis, synthesis, and evaluation. So I'd like to put forward to you that I'd see kind of FRCS aiming at levels 1, 2, and 3. So turning up, being able to know a background of something and the vague idea of how to do the operation and who needs that operation. But this higher level thinking, this level 4, 5, and 6, is what we're aiming for in the hand diploma. So the ability to weigh up different arguments for whether certain operations or procedures or treatments are relevant, the pros and cons, and be able to have a really deep discussion about them on a high level. So how is the diploma assessed? So the big component is the course book. And the exam, although the exam is the bit everyone gets worried about because you're sitting there face to face, trying to get your way through a viva in front of people, which people do worry about, the exam is the cherry on the cake. The course book and that ongoing learning over the course of a year is the main thrust of the diploma. And what that course book involves, and I know Mark's going to talk about this probably in more detail, but there are 32 tutorials, 19 web-based assessment, and then what I call special tasks, because I haven't got a better name for them. And those are the rehab lecture, the video of an operation, the trauma algorithm, the review article, and the conference critique. So that whole year's worth of course book tasks and tutorials and web-based assessment is then examined at the end of the course, hoping to cover the breadth of all of that knowledge. And it's estimated that really to make a good job of this, you need to be devoting about 1,200 hours of study to it. So a bit more educational theory. The idea is that you are going to drill your tutors for all their years of applied clinical knowledge. So the stuff that you cannot get out of the textbooks or from a Google search. The real nuances of why certain operations work in their hands, why they don't, how they treat certain patient groups. And tutorials are your chance to really nail down those tutors. You're never going to get such a good chance and a good excuse to sit people down and absolutely suck every bit of information from them that you possibly can. That's why it's so important to prepare for your tutorials, your case-based discussions, and your knowledge-based assessments. It's no good turning up and having a very basic discussion that anyone could have read out of Greens or on Wikipedia. There's no point in that. You need to come fully prepared with the basics to take things to that higher level. So just to reassure you about the exam, and I know Jeff's going to talk a little bit more depth about the exam from your side, All of your examiners are constantly assessed. So when you do have your skills stations, there'll be 2 people going in and out, and currently that will be Andy Logan and Charles Palethorpe as our external examiner, and they are assessing your examiners to make sure they're being consistent and fair. In general, it is a friendly exam. Those examiners are there to pass you. They're not trying to fail you. They're very respectful of your seniority and also the fact that they're going to be consultant colleagues with you, for the rest of your careers. So it is, as much as possible in this stressful situation, a friendly exam. The questions for the MCQ and EMQ and skills stations are very carefully prepared. So leading up to the exam, over that year, the committee meet 5 or 6 times to refine and change and discuss every single question that goes into your exam. And every time questions are used, they're improved using feedback from the examiners for the Viva stations. And there are some exams. We do have an examination question bank. However, those questions, every time they go into the exam, are changed slightly. So I would caution that you may have heard of certain topics being covered in the exams previously, but try not to get focused on the detail of what questions were asked, because they may subtly be different when you sit the exam, because we're constantly refining and changing the emphasis on those questions. So what are the secrets of success? Make the most of all these opportunities to learn. It's really your time to develop as a hand surgeon. Don't underestimate how much prep you will need to do for the exam, but that prep will be easier if you've invested all the time in the tutorials and the web-based assessments and the other tasks. Do check the handbook for the marking descriptors, for the special tasks and for the exam. And do look at the reading list, because questions in the MCQ, EMQ and skills station do cover details from those from that reading list. At this point, I'd like you all to get your diaries out, because any of you who are considering sitting the October 2021 exam will need to submit your application of intention to sit by Sunday the 25th of July, and that application form will be sent out to you by Ruth and needs to be submitted to her by that date. The October exam this year is going to be a busy one, and logistically will be tricky for us, given that we had to postpone October 2020, and very recently we made the decision we're going to have to suspend this March exam. So we're going to have a large sitting. So please, if you are going to sit October this year, let us know as early as possible. That's the deadline. You can let us know as earlier than that. And the same with the coursework. The course book deadline is Sunday the 5th of September, but you can submit it before then. Also, your video, algorithm and special tasks, you can submit them before then, ideally, please, because with a big sitting this year, to get our assessors to assess potentially up to 30 candidates' videos and algorithms between the 5th of September and then the first week of October is going to be very tricky, and it might mean that your result is delayed because we won't have had a chance to fully assess everything. So by all means, please do submit your special tasks early. So problems we see with candidates are trying to complete the whole course in too short a time. You put yourself under too much pressure. Not preparing for tutorials means you don't get the most out of it, and rushing your DVD. And so I keep calling it DVD, it's video, isn't it now? Or I don't know, video file or JPEG or whatever. Do take the time to get it right. Some candidates do find there's a timeline that's useful on the BSSH website, which you'll have been given a link to. And instead of having to flick forwards and backwards through your course book to ascertain how many things you have still yet to get signed off, the timeline shows you on one page how far you've got, and that can be quite useful. So I would recommend using that. So just as an example of doing a quick bit of maths, if you are intending on sitting in October this year and you haven't yet got anything in your course book, dividing up the number of tutorials and web-based assessments, you would need to complete a minimum of 2.5 a week for the next 6 months in order to have your course book in on time. So something that commonly people get caught out on is having a last minute panic when they realise that they haven't kept up to things on schedule. So once you've achieved your diploma, so that means your course book has been validated. And yeah, one of my special tasks on the day when you're having your skills station vivas, I individually go through every single one of your course books to make sure everything is signed and up to date and properly sorted. So your coursework book will get properly validated. If you've submitted your external assessments and they've been passed, and you've passed both the written and the viva examinations in one sitting, you have achieved your diploma. Well done. Your certificate will then be presented at the BSSH spring meeting or posted to you if you're not attending or prefer that. One of you will achieve the Vmqs gold medal as the highest scoring examination candidate of that sitting. What next? Well, once you've recovered from all that drama, there's the opportunity to enrol on the Masters, which Andy Logan's currently the chair of, and other things you can do to give back to the diploma. So you can become a tutor for the diploma or a supervisor. Once you're 5 years down the line as a consultant, or slightly before, you can do your FRCS examiners course and observe to therefore, once you are 5 years as a consultant, start examining with us. You'll get a notification through the BSSH Secretariat when there are upcoming committee member posts. You can help run this course or help run the exam. And you'll be invited to the Diplomats Dining Club once a year. Okay, that's me. So let's stop share. And a bit of a whistle-stop tour. I haven't been checking the chat, so please feel free to...
no chat. I will check that through the course. Yeah.
Okay, cool. Well, feel free to ask me questions at any point once your caffeine hits kicked in this morning.
Okay. And yeah, all the way through this, I will respond to things if you just put them on the chat at the bottom or at the end. But thanks very much for that, Helen. What I'm going to do now is there's some duplication there, but to run through how I tackle the diploma, I did it during a fellowship. This is pre-recorded, and one thing I forgot to mention in this is you have a course booklet which you'll fill in, and I would seriously recommend each time you get something filled in, take a photo of that page, because if the course booklet vanishes or gets stolen out of your car, not that they'll steal just that, but they'll steal your laptop with it, or you spill coffee on it or something, it is very, very painful then to try and backtrack, especially if you're very close to the deadline. So if you've got all these pictures on your phone, you can at least upload those, photocopy them and sort them out. That's my top tip on potential disasters. So I'll start the screen share, and then as I said, I'll keep an eye on the chat if you just want to ask any questions there, or speak at the end. This is a presentation on how I completed the hand diploma. I did this during a fellowship in hand surgery, but many of the discussions would be relatable if this has been tackled during a consultant post also. The most important thing you can do to be successful is be organised. You need to know what you have to do, book tutorials before you start your fellowship or as soon. Okay, I was just saying there's quite a few people saying they've lost the audio. It's a little bit quiet, but did it just go completely or? Yeah.
It went completely, Mark.
Fine. I'll try that again. So if not, then I'll voice over it. If I get more saying it's gone completely, I'll just start voicing over it then. Okay. So within there, I'll just have to go through the whole thing to the end and then start it again. A bit more detail in knowing what you have to do is really looking at every little aspect within the course booklet, knowing the different modules and knowing all the tasks involved. So this is my template. I appreciate it's now up to date because there's 8 modules, but this was color-coded for myself, and each of these blocks, the basic science, soft tissue, joints, fractures, osteoarthritis information as you go through, were color-coded and color-coded to chapters within greens. So that's as many people's main source of reading. Obviously, you need to read around and some literature and papers, but the main reference book was greens for myself. And therefore, I knew which chapters fit into which module to save me time when I was trying to flick through and glean the information and read prior to tutorials. You can also see on here that there is noted in each tutorial which KBAs, which CBDs, which KECs, and other aspects that you need to do, such as the algorithm. I chose to do it on some carpal instability, and therefore I put it into module 3, so I'd be able to read around that while I was revising for that module. Just to be up to date, here is, as I'm sure you're aware, the modules that have been slightly adapted to make the additional module taking Dupuytren's disease and tumors and vascular disorders out of some of the other modules. And then the final module, which is module 9 now, is the exam. So within the frame of knowing what you have to do, you need to know the time frames. You need time to set aside either as a consultant or when you're going to have access to tutors during your fellowship. Obviously, there are resources to allow remote tutors if you're not in a department, or if you leave that department and you want to continue some of your tutorials, but it's easiest to have tutors who you're working with or within a fellowship. There are 32 tutorials and 8 KBAs, and I include 8 cancellations in there because you will get some cancellations due to overrunning lists, overbooking, annual leave at short notice, or study leave. And that equates to 48 slots to book within your time. So if you then do a fellowship, a lot which starts in February, and you have to hand this in all your coursework in January, minus your own 6 weeks leave, that leaves 42 weeks. So less than weeks than you've got tutorials or KBAs to do. So it's very tight to do within a year. We've also, within all this, got the other projects, the video, the review article, algorithm, scientific review, and rehab talk. So if you look at an 18-month period with 9 weeks leave, and this is only 69 weeks, so an easier time frame to do the 48 slots in. My feeling, as having done the modules and also taught it a lot, is that if you do more than 1 tutorial per week, you're probably not doing justice to that tutorial or to yourself. There's a lot to be read, a lot to be gleaned from it, and you're really there to come to the tutorial with most of the information and just get the tips and tricks and tie things together from the consultant who's teaching you, rather than to learn the basics, because that's not really the point of these tutorials. Clearly, if you have a specialist interest in some areas of orthopedics or plastics that you already have knowledge in, then you may be able to do that tutorial and another one that week, but it isn't ideal. The insider information aspect is to get as much information before you start the fellowship or you start working for these tutorials as a consultant to hit the ground running. So to know how each consultant divides their modules and runs their KBAs, which you can glean from previous fellows or previous people who've done the diploma in the department, which consultants work on different days and therefore the best days to teach on. This may have evolved recently because usually it would be the fact that you'd want to be in the hospital straight after that person finished their clinical theatre to do that tutorial. But now a lot of tutorials are moving for safety purposes on to Zoom or to other platforms, and therefore you could do this remotely even when at home or on leave if you liked. You need to book the appropriate tutorials for each block, so it's much easier if you're having to do a block in paediatrics hand surgery to do your paediatric tutorials then, so really have some foresight over your timetables for the year. And beware leaving anything to write at the end before the deadline, because the deadline being in January, you've got Christmas and New Year at that point where a lot of people on leave. You might not be able to get those last few modules done in a reasonable time frame. Ideally, you want to book a few dates before you start. So if you're starting in February, you don't want to be then getting to know everyone and book your first tutorial date in the middle of March. You've already lost 6 weeks of that very tight time frame if you're planning to do that within a year. And if you can complete your review article or some of the other tasks before your fellowship starts, if you register for the diploma early, that's ideal. Is it just one distracts us from your fellowship trying to work on these things, and also from the reading you have to do for these diploma modules. So, I'm not sure the audio is working for this particular slide, so I'll just run over that. Can you hear me, Matt? I can only see your face. Yeah, great. So there are obviously these miscellaneous or special tasks, of which the video is the first one I've highlighted, that we have contacted the different consultants who actually mark these tasks, so the video, the algorithm, and see what the most common problems or reasons these tasks are sent back to the juniors for editing or revision. And for the video, it's really not doing what they should do. So within your course booklet, there's not only a list of operations you can perform and video, there's also a step-by-step list of things you have to include, in particular things like being seen to be doing the WHO checklist or applying the tourniquet if a tourniquet is used, which are tasks that so often there's a number of people involved with, but you really need to take it on board and do it. So one of the aspects in a video example we have, unfortunately I have not got available today, the fellow actually wrote the whole checklist on the whiteboard and went through it in order and made sure it was filmed, and then had no real audio apart from the WHO checklist on the video, and the rest of it was audioed over the top rather than in theatre audio, which is much clearer and easier to listen to. From the algorithm, I've had some feedback from David Hargreaves, who marks these, and his feedback was really to try and keep it clinically relevant to day one as a consultant. So you don't need to do sort of crazy minutiae, because that's not easy to get an algorithm that will help you in your day-to-day practice or hand surgery practice. Keep it to one page, and that's the algorithm. If you're using a number of references, which we recommend, then those can go on a separate page, because sometimes rather than squeezing them all on, but have the crux of the algorithm onto one page, and be logical with it, and use boxes, shapes or colors to aid the clarity and the flow. And what I found when I've been reviewing these for the fellows is that you need almost someone non-medical to read it and see if they can actually get out of a box, because you often find that there is not a logical path, or there's dead ends within that, because you, after spending hours and hours on it, you can't see where the dead ends are anymore. So sometimes a non-medical partner can be very helpful. If there's more than one treatment, you really need to choose which one you want. You can't just say this fracture has gone down this pathway and there's 4 different treatments for it. You need to say which one you choose, why, and evidence that. And if you use 5 to 8 references of the hopefully original articles or systematic reviews, not textbooks or review articles, because they're a bit too global. Regarding the review article, Jeff Hooper has already prepared a paper on that, which I think we've got good feedback on. And then the other miscellaneous bits that people tend to forget about is all the CVDs and the DOPs. And it's not that you forget to do them in the end, it's just that you often, I'm sure you've known from ISCP, miss lots and lots of opportunities to do these things. So if they're in the forefront of your mind and on a list on your phone of what you need to do, just keep checking those so you actually have, so get the opportunities when you can. The audio of the WHO checklist. Sorry. The audio of the WHO checklist, you have to include aspects of it, obviously not the patient name or the details. Sorry. That was just an answer to Paul Malone's question. Although I've highlighted the fact of being organised, my number one tip is to write notes. This diploma is not just an exam for you to pass to get a job. This is to give a basis which is better than you would have had to become a hand surgery consultant, and particularly for the orthopaedic consultants to get a better grasp of the plastic surgery side of hands and vice versa. So I wrote notes and I still use them to teach on the diploma now. The age revision when you come to the exam, age future revision and consultant jobs, and it will aid your teaching. Thank you very much. I'm happy to answer any questions now. Okay, so I can answer any question. I've only got one on the chat, which I think I answered there. Sorry, there's people trying to contact me with phones and various other things, but I hope that's sort of clear about looking over all the aspects of it. They do take time, and some things like the review or the algorithms, you may get sent back because they're not adequate. So that's something to bear in mind, with Helen mentioning that you need to not just send them in on the deadline, try and send these off earlier so you've got time for to edit them. So there's no other questions coming up on the chat there. Then I'll hand over to Jeff Hooper, who'll look through the exam format, structure, and what to expect when you get to that final hurdle.
Okay, just sorry, I just okay, can you all hear me fine? I'm just going to talk for a few minutes about the examination, so-called, the format and structure and what to expect on the day. It's a final assessment of your training, rather than a traditional examination. And you've done all the training, so you're well prepared, and the examiners are not there to fail you. As you've heard already, they're going to treat you courteously and as a colleague, and the whole basis of the examination is to see and hear how you deal with everyday conditions and procedures. The bottom line being, are you ready for independent practice as a hand surgeon? Day one as a consultant, although some of you, of course, will be consultants already. Now, as we've heard already, the examiners are a friendly lot. They will treat you courteously and as a colleague. And this is a picture of the examiners, and you can see they tick all the boxes for diversity, gender, and being very, very pleasant people. The examination itself is in 2 parts, and it'll be over 2 or 3 days, depending on the number of candidates. And in October of this year, it might be even longer than that, but we'll cross that bridge when we come to it. On day 1, there's a written paper which lasts for 2 hours and consists of 60 MCQ questions, multiple choice questions, and 10 extended matching questions. And the subsequent days are the skills stations in the OSCE format, and there are 8 of those, 15 minutes each, and a published paper station. And the pass mark in both sections is 60%, and you have to pass both sections. So the MCQ and EMQ questions are based on the 8 course units, the topics that we've seen outlined already, and they are evenly distributed over the whole curriculum. So you won't have an exam where you're sort of hammered on one particular aspect. It's evenly weighted so that you aren't stuck in one area, like the old FRCS when the written paper was on cholecystectomy, the patients were cholecystectomy, and so on and so forth. And as we've heard from Helen, the questions are exhaustively developed. Lots and lots of time is spent on them. And they are changed from exam to exam, so you can't memorize them. Before the exam, they're analysed, and they're also analysed after the exam. The number of marks that are given to each, or the number of answers that are given to each section, are looked at very carefully, because if you take an extreme, you'll find that everybody got it right and everybody got it wrong. It doesn't happen very often at all, but it's looked at so that we know if that's happened. So let's have a look at the particular types of questions. First of all, the MCQ, and their best answer questions, and a choice of 5. In medical areas, there is no single right answer to most questions. So you've got to pick out the best answer from the alternatives. If you get it wrong, you choose the wrong answer, then there's no negative marking. You don't lose a point. But don't try to be smart and answer more than one part, because then you won't get anything, even if one of them was right. So let's show one here. The keywords are for the examiners to pick out the actual topics, so that, as I say, there's an even spread throughout the syllabus. The STEM question is, which statement about digital flexor tendons in the adult hand is most appropriate? And there you've got your 5 choices. So let's just take them one by one. Elastin accounts for 15% of fresh tendon weight. If it did, we'd be bouncing around all over the place, but it's about 1%, so we can draw a line through that one. Tenoblasts are the predominant type of cell. Well, it's adult tendon, isn't it? So tenoblasts are in the juvenile, infantile tendons. It's tenocytes, mature tenoblasts, so draw a line through that. Major component of fresh tendon is collagen. Well, there's lots of collagen in tendon, isn't there? But that's the key thing, fresh tendon. As someone once said, even the Archbishop of Canterbury is 85% water. So collagen's no exception to that. There's lots of water in it. So collagen is not the major component, although there's lots in it. Nutrient arteries lie in the mesotenon. Have to come back to that one. Type 3 collagen is most common type in tendons. Well, we know it's type 1. So in fact, we've drawn a line through 4 out of those and come back to nutrient artery. And that, of course, the mesotenon is represented by the vincula. So you either know it and go straight to it, or you can come at it by a process of elimination. And you'll use both of these techniques when you're answering these multiple choice questions. I've put another one in, which I'm not going to go into in any detail, but this is degenerative osteoarthritis and thumb. Those are the 2 topics. And here we have a 65-year-old woman, and surgical treatment's been advised. Which of the following statements is most applicable? And you'll see that this is a little more complex in that the sentences are longer and so on. So in other words, you've got to put a little more thought into just carefully reading the sentence and coming up with your answer. Now, I'm not going to give you the answer to that one, but just to show you it's a different type of a question in the way it's set out and requires a certain amount of knowledge. Right, extended matching questions, they're a different format. They're possibly going to be used increasingly in the future in all sorts of exams, either alone or with best answer MCQ questions, which is what we use at the moment. They test knowledge in a more applied way, as we'll see when we look at an example in a moment. And at one point, educationalists preferred them, but as always with these things, there's sort of fashions that come and go, and perhaps they're going off them a little bit now, but we won't get into that. The extended matching questions come in this format. There's a lead-in, which is the instruction, and each question has a numbered list followed by a list of options with letters. And for each number, you select one letter, only one, that's most appropriate. And you can use the options once, more than once, or not at all. So that is the standard format for an EMQ question. So for each number, and these are called vignettes or scenarios, you match the most appropriate statement, which is the answer option. For an EMQ, educationalists say that 5 scenarios is the optimum number. So we've got 5 there. And for the answers, the optimum number is 8. So you've got, for each one, you can choose 1 out of 8 as your answer. And I'll just show you an example of an EMQ. Right, so again, the instructions are the same. So for each type of amputation, match the most appropriate statement from the lettered list. And you've got 5 sections here. Amputation of the index finger through the metacarpal. Well, it shouldn't be commonly associated with painful neuroma. The palm is intact. It's just lost one side of it. So it doesn't cause small objects to fall from the palm. There's no reason why it should be followed by scissoring of the fingers. Results in considerable weakness of power grasp. Well, yes, it does, because you've lost the width of the hand. So that's a possibility. And the quadriga effect, well, why should that happen? So there we are. We just go through. I've only put 5 in there because, but it should be 8 if it was following the rule, but you'll get the idea. That's the main thing here. So I'm not going to go through every single one of these, but we'll just come up with the answers. And here you see amputation of the index finger results in considerable weakness. So does amputation of the little finger through the metacarpal. Amputation of the middle finger through the proximal phalanx. Yes, it causes objects to fall from the palm. Likewise, the disarticulation of the middle finger at the Mcpj. And ray amputation of the middle finger could result in triggering of the fingers. So you'll see there that 2 of the questions have the same answer, and that occurs in 2 other questions as well. And then there's another one that's 3. So they're all distributed about. You can use them once, more than once, or not at all. So that's the MCQ EMQ 2-hour paper, 60% pass, and the answer sheet is marked immediately, and you'll be told the results. If you have failed, you can still sit the clinical, but you won't be given a pass, even if you pass the clinical exams, because all parts of the examination must be passed at the same diet. The clinical skills section takes the form of 9 15-minute OSCE stations. 8 of these are based on the units, and 1 is the published paper question. You'll get a rest in the middle, and as has been mentioned and stressed several times, the examiners will try to put you at your ease, treat you as a colleague. You have 2 examiners, but you also have other people in the room at times, because the examiners are being monitored, and if they don't treat you properly and also carry out the exam in a proper way, then they will be told in no uncertain terms. The stations are structured, as we'll see this afternoon. The examiners are working, as it were, from a script. They ask you specific questions and they have to get through those. So if you're stalling and bluffing and trying to waste time, then you won't get through them all. And therefore, obviously, you won't do yourself credit on that particular topic. The questions are open. So you're not going to have a binary question, which is either yes or no, or possibly I don't know, but they're open so that they are an opportunity for you to discuss and describe. And as I say, they reflect the subject units and based on your everyday experience, so they have various components. And it may include practical procedures, and then the final one of the 9 is the published paper question. I say final, it doesn't come at the end. It may come at any point within the rotation through those 8 topics. So as far as the clinical skills section is concerned, obviously, depending on your experience, you won't do equally well on all the questions, but you must pass 3/4 of the skills station, and the pass mark is 60% for each. If you score less than 30 on 2 stations, then you won't pass no matter how well you do in the others. So the examiners are looking at how you approach a topic as a day 1 consultant and based on the experience that you have. If you don't know, say so and move on, because, as I say, there's a certain amount of material that has to be got through. So if you're bluffing, then we won't get through it all. If you can mention a pertinent paper from the module reading list or from anything else you've read, then do so. But you must be more specific, quite specific about it, so that, the author or the title or whatever, or the main findings come across. As we'll see from the marking sheet in a moment, you are actually asked to cite a published paper at times, and this is based on the reading list. So if you can't quote a relevant paper from the reading list, then it's difficult to score a point for that particular section. So that's the clinical aspects, the 8 sections. The published paper question, at the end of the written exam, you'll be given a recently published paper to study overnight, and you'll be asked questions about it, such as the study design, level of evidence, use of statistics, could it be done better, will it change your practice? And these are all the kinds of questions you ask yourself when you read any paper, aren't they? So again, this is not a sort of difficult section, and there's no trick questions or anything, just as in the rest of the examination. Now, you're given it at the end of the written exam to study overnight. Don't discuss it with your colleagues, but do look up and study aspects of the paper. You're perfectly at liberty to look up things on the internet and so on, just to expand the knowledge about the topic. Now, when the examiners are scoring your replies, they use a station scoring grid, and this has a list of specific questions that they've got to ask you. So this will vary as to how many boxes there are here. And the other side here, the areas that have been marked in pink, are what are relevant to these questions. So this question might be something that tests your score basic scientific knowledge and may have an element of practical skills in it, for example. And each one of these boxes is going to score 4, up to 4, from 0 to 4. And as I say, the boxes should be scattered evenly over this chart. So for each of these, 4 possible mark is 8, likewise 8 here, 8 here, 8 here, so that the overall score is out of 32. Now, as I say, these boxes will vary as to what they're testing for each particular question. So the examiners score each shaded box from 0 to 4 using the marking descriptors, which you have in the diploma book, and that tells you exactly what they're looking for. And the pass mark is 19 out of 32, which is roughly 60%. And again, the examiners have to fill this in and put in comments for feedback and so on. So after all these bits are completed, the examiners will meet at the end of the examination, and the candidates scored, but they aren't displayed. Candidate scores are displayed, but are not changed. There's no horse trading or anything that goes on at this point, and you will have actually given the method by which you want to be notified of the results on the day of the written exam, phone, email, text, or whatever, so you'll know straight away. And if you're successful, you have the satisfaction of completing the training. All the hard work that you've put in will have been recognized, and you'll have that great satisfaction that comes when you've done a good job. In the event that you're unsuccessful in this module, then you've done all that work. You will be given feedback. Don't give up. Try again. You'll have had valuable experience from just simply sitting the part of the examination. Okay, so hopefully that's been all right. Let's go out of that. Did that come across all right?
Yeah, it's very good, Jeff.
Okay.
Questions on the chat, but I don't know whether anyone wants to pose a question now. Okay. You explained everything so well, no questions.
Well, there's plenty of time for questions later on in the day.
So looking at the timetable now, we have coffee, but most people were warming their hands on coffee on the video when I looked. So we were going to just have a refreshment break for 5 minutes rather than 15, unless anyone specifically objects to that. We can't shorten the day because those examiners for the afternoon are only available for the afternoon, but we could make the lunchtime break longer because there is less handover and movement around on a Zoom meeting rather than there is normally, so it's moving a bit faster than previously. Unless anyone puts on the chat or unmutes and says so, we'll just have 5 minute refreshment break, and we'll come back and we'll do the demonstration of skill stations, Vmqs at, well, let's make it easy, half past 10, so that's 6.5 minutes. Okay? Okay, so what we'll do is I'll hand you over to Rajiv Jose, who's going to play the video of the demonstration skills that we've taken earlier this month.
Thanks, Mark. Just a couple of points about the video. So this is what is traditionally been called a good candidate station, a demonstration of how a good candidate would perform in the exam. In the past, the station has been a bit scripted in that the examiner and the candidate had prior knowledge of what questions might be asked. But this time, because of the lockdown, we had to sort of just make it up, and the candidate didn't know the questions to be asked, but he had prior knowledge of what the station would be. So I don't know whether it's fair to call it a good candidate station. I would just say it's a candidate station as it would be in the exam. In the real exam, there would be 2 examiners, and they would swap at half time. And when one of them is asking questions, the other one would be marking, and vice versa. Here, there's just one examiner. The other person in the exam room is a volunteer who is sort of, it could be a patient or it could be just a volunteer where you would have to ask questions, so demonstrate some clinical science, etc. So I'll play the video, and in the end I'll just show you this the scoring grid for this particular exam. Vmqs in the meanwhile, if that's okay.
Okay. So if everyone can get their sort of papers and pens together, we'll try and run this once we've sorted the audio issue out.
I had done a trial run and it seemed to have worked, but I'm not sure why it didn't.
Okay. We're I'll give you all a few seconds to get your paper and pens together, and then we'll start the MCQs. Rajiv, can you hear us now?
I can hear you now, actually. I'll just try and log on to another device and see whether the audio, so the video works on that as well. So candidates, if you all can get a pen and paper, because what I'm going to do with the Vmqs is to share a PowerPoint with the questions, and you can just mark the answers yourself. In the end, we'll run through the answers and you can self-mark it just to see how you've done. I haven't timed the questions. We'll just, play it a few seconds per question, and it's not a simulation of the real exam, because the real exam, it is, of course, you have the time constraints. It's just to give you a flavor of the type of questions which we ask, and similarly just with the EMQs. So I'll share the Okay, so hope everyone can see the screen. Okay, shall we start then? Okay. Okay. Next question. Okay, next one. Okay, number 4. We are now moving on to EMQs. that's the end of the MCQ, EMQ question. So we will discuss the answers in a minute. I'll just try in the meanwhile to see if I can try the PowerPoint from, sorry, the video presentation from another device. So if you just bear with me for a few minutes.
Just while we're setting this up, if anyone does want to ask any questions about the whole diploma, there's a factor here that can answer it if you like. Or have you got that now, Rajiv? Ah, sorry, beat me to it.
Yeah, I got it now. Okay. So the first question was, which of the following is a contraindication for using collagenase for Dupuytren's disease? We don't have collagenase anymore, so I'm not sure if you'll get these questions, but when we use collagenase, we could use it for PIP joint contractures. We could use it for patients on aspirin. That was one of the only anticoagulation which was still permitted. Patients with latex allergy is not a contraindication. Patients on clopidogrel actually is a contraindication because as per the manufacturer's instructions, you could only use it for patients on a single anticoagulation and that to aspirin. And previous collagenase in the last 6 months is not a contraindication. So though a lot of us would possibly use it on patients on clopidogrel or warfarin, if you strictly go by the book, that would be the answer. Second question was about a child with a ganglion. Your advice would be? Third question was about Dupuytren's diathesis, the Houston's diathesis, and the answer for this question is plantar fibromatosis. So these are the type of questions you possibly will not have in the exam, though I tried to masquerade it a little bit like a clinical question saying, oh, you're looking at an X-ray. So the actual question is, which is the first bone to ossify in a child? So the answer is capitate. So this sometimes can catch you out because you would think there is a flexion contracture of a PIP joint, midline laceration. Oh, why don't I do a Z-plasty? The key here is actually 6 weeks here. So if you skim read a question, you can sometimes miss it. So it's really important that you read the questions carefully. This again, Wassell's classification of a thumb duplication. At first glance, you might think, oh, it's duplicated at the metacarpal level, so it should be a type 4. In actual fact, you can see it's a tripharyngeal thumb, which makes it a type 7. So EMG findings in a focal dystonia is a co-contraction of the agonist and the antagonistic muscles. So patient with weakness of grip following a tendon repair. So at first glance, you would think it could be just adhesions between the tendons, which is true actually, but the better answer here is actually a quadriga effect, because what the adhesions have done is it actually has limited the flexion of all the fingers. So the question here is, what's the source artery for a lateral arm flap? It's a plastic surgery type question, but as it comes in the soft tissue module, it is sort of considered within the remits of hand surgery. It's unlikely you'll get questions like these because it's a factual question trying to pass off as a higher order question. So the actual artery supplying the flap is the posterior radial collateral artery, which is a branch of the profunda brachii. Commonest cause of tendon rupture in a rheumatoid patient is it's a picture question. Patient with a painful cold sensitive fingertip showing a little lump. Slightly unusual location, but it is a glomus tumor. Multiple carpal fractures, radial styloid fracture, treatment should be. Okay. I think that picture is slightly obscured your reading. I don't know whether it was the case when you were reading the question. It's a jersey finger with a big volar fragment, and Lady Packer type 3. Treatment would be this is a question which makes you think. The patient's got a laceration to the upper forearm, median nerve injury, has had injury to the bellies of FCR and FDS. So 6 months later, patient's got sensory recovery, but a lack of opposition. So which opponent's plasty would you choose? So along with the opponent's plasty, you also have another choice, which is a fusion of the CMC joint in opposition, which is okay. It does keep your thumb in opposition, but you lose your passive movements of the CMC joint, so it's not ideal. So you are looking for an opponent's plasty. Question is which one? So B is something called a compromised opponent's plasty, which you use sometimes when you have a combined nerve injury. So amongst the other 3 opponent's plasties, you have the FDS ring finger, which you cannot choose because the patient's had a repair of FDS or damage to previous FDS. Palmaris longus, again, if you have had a previous median nerve injury, you wouldn't use that. In any case, it's not a tendon transfer for position use for an adult patient. So that leaves you with an EIP transfer. An EIP is innervated by the radial nerve, which makes it suitable to be used in this case. So the answer is E. So this is about a patient who's had a distal radius fixation and complaining of pain, crepitus on movements. So it's irritation because of the metal work, and the treatment therefore would be a removal of plate. It's not a great question. It's got a lot of distracting choices. None of them, some of them don't make sense really. Patient with frostbite. Unfortunately, the degrees turned out as question marks. I'm not sure why. Actually, it wasn't on the PowerPoint. I think I was sharing, or when I was playing, it just showed as question marks. It's basically degree centigrade. So treatment of frostbite. At one point, there was a thought that you should do gradual rewarming. The current thinking is that you should actually do rapid rewarming at 40 degrees. patient with loss of supination following a distal radius fracture with a congruent druge on CT scan. This is a question which I inherited from one of the previous courses, and the answer seems to be soft tissue release of druge. It's not something which I have seen done much of. I personally would have done a bit of a manipulation to see if I could get it any better, but that seems to be the answer. So the views for assessing ulnar variance. It's a fairly standard question, 90 view. The biggest advantage for using a 4-strand repair as opposed to a 2-strand repair is actually, that's a typo. My apologies for that. The answer is actually D, not B. It allows early active mobilization of the repair. So the answer is D here, okay? It's not B. Wattenberg syndrome can be treated surgically by releasing brachioradialis. Okay, not that I've done many Wattenberg releases, but that's the answer. Moving on to the Vmqs. So you can choose the choices more than once if you have to, and some of them don't have to be used at all. So the first question was, which muscle has a dual innervation? I'll probably just play all the answers together. So answer is brachialis muscle, which is supplied by muscular cutaneous nerve and by radial nerve. Inserts into the base of the second metacarpal. Answer is E, which is extensor carpi radialis longus. Brevis is inserted into the base of the third metacarpal. Muscle commonly used in tendon transfers, wrist extension is pronator teres. Muscle has been used in Brand transfer of anti-block correction. Brand transfer is for ulnar nerve palsy, and the muscle used is extensor carpi radialis longus. Now, there can be a little bit of ambiguity because Brand initially used ECRB tendon for his transfer, but the currently used Brand transfer is using ECRL. Median nerve passes through the two heads of, you have B coming again, which is pronator teres muscle. Again, another anatomy question. Tendon of this muscle travels through, sorry, I'll play the answers. Travels through its own compartment in the extensor retinaculum. So answer is extensor digiti minimi. This muscle takes origin from ulnar and intraosseous membrane. Answer is extensor indicis proprius. It's one of the few muscles which come from the ulnar side, but is inserted on the radial side of the hand. Inserts into the base of the first metacarpal is abductor pollicis longus muscle. Lies in the second extensor compartment is extensor carpi radialis longus, and this muscle has often has multiple slips, and that is abductor pollicis longus again. Question on nerve compressions. Ulnar nerve compression at the elbow is Osborn's ligament. Upper arm is arcade of Struthers. Radial nerve at the forearm is arcade of Frost, confusing eponyms. 14, ulnar nerve compression at the wrist is Gion's, and median nerve at the wrist is carpal tunnel. Bit of a plastic surgery type question. Granulocynostosis syndrome is F, which is complex intactily. So things like aperts, etc. You get complex intactily, where there is fusion of the digits with bone and nail fused together. Constriction band syndrome is acrosyndactyly, where the tips of the fingers are fused together. Cardiac defects and hematological anomalies is radial club hand. We don't use this term anymore. We call it radial hemimelia or radial longitudinal deficiency. Chest wall anomalies is symbrachydactyly. That's what we call pollen syndrome, where you get ipsilateral limb anomalies with hypoplasia of the chest wall, absence of pec major and sometimes lat dorsi. Vertebral anomalies is again radial longitudinal deficiency, D. X-ray views. So ulnar variance is, we already had that question in the single best answers, that is 1990 view. Scaphoid fractures is the zeta. Metacarpal head fractures is the Brewerton's view. Also for metacarpal OA, you can use that view. First CMC joint is the Roberts view, and for assessing glulas lines, you have the standard AP view of the wrist. This is about wrist arthroscopy. So vascularly seen from the 3-4 radiocarpal portal is 26D is Testude and Coons. Classification for assessing scapholunate ligament injuries is 27A Geisler. Portal best to visualize the STT joint is 28B radial midcarpal joint. Portal most likely to injure the dorsal branch of ulnar nerve, 29E is 6U. Portal most commonly used to probe TFCC is 30C6R. Another risk question, tear in the space of Poirier is a perilunate dislocation. Positive Kirk-Watson test is scapholunate. Schoffer's fracture is radial styloid. Injury changing grade 2 to grade 3 is the lunotriquetral ligament B, and Essex Lopresti is the interosseous membrane tear. The last set of questions is about splints. So central slip splint is the Kapner. Wall plate lax or Schwannecking, you use a figure of 8. Extensor tendon terminal injury or a mallet finger, you use a stack splint. Carpal tunnel is Futuro, and for MCP replacement, you use an outrigger splint. So that's the end of the MCQ Vmqs, and you can sort of mark yourself and see how you've done. Some of the answers I know are ambiguous, and even the real exam, sometimes you come out thinking, well, I'm not sure whether there could have been 2 right answers, but some of the ambiguous questions do get removed from the real exam, so that is always a standard setting for the exam. So I'll just try playing the video again, but if you have any questions about the previous talks or anything about the diploma in general, it's a time for you can put your questions on the chat box.
There's a question online which I think I know the answer to, but I'll just clarify. It was about the paper question and whether they can bring notes. So there is a point for you to sit down and read the paper again. That's actually factored into the exam, so the paper's in front of you. Can Jeff or Helen or Andy advise me? Can you bring? I know you can bring your notes to that, but I don't know whether you can bring them into the station. Can you?
No, is the answer, because it's, I mean, by all means, make notes and so on, just to, go through the material and so on. But, it's a face-to-face talk with the examiners and the candidate. And if you keep referring to notes and so on, that can break the thread. So, you should have, if you've made notes, have that in your mind. You don't need to, and you've got the paper in front of you as well, so that can be referred to. So from a practical point of view, it doesn't really cause a problem, I don't think. Helen's got any comments about it?
Yeah, I was just going to come in there. So, remind candidates they will get another chance to reread the paper in peace in a room by themselves before going into the paper station. So they've got a time to refresh themselves, and then they can make notes. They'll have a new copy of the paper given to them. They'll have a pencil at that point, and they'll have some quiet time to do that.
And so they can't bring their notes from home into that room to read the paper? No.
No.
Any luck, Rajiv?
I'm just going to try again, Mark. So let's see. So somebody said there is an option for choosing audio for the sharing. Can't see any actually.
It's when you actually log in at the start, you get to choose it, but you must have chosen it to be speaking. So I'm not sure what the issue is. Sorry.
Okay, I'm just going to fast forward a little bit and see if you can hear the audio.
No.
Did anyone hear any audio? Nope. You can just see the video, isn't it?
So shall we have a play with this, Rajiv?
Okay. Okay, I'm just going to try again.
Patient who is 60 years old. She's a housewife.
Brilliant.
Okay. Yeah, I found a little button where it says to share computer audio, I think.
This is a clinical skills station for the hand diploma examination. Come through.
Hi, good morning.
Hello. Take a seat. So this is a clinical skills station. What we have here is we have some radiographs. I'd like you to have a look at them. This is a patient who is 60 years old. She's a housewife and she's got discomfort in the base of her thumb, and it's worse with twisting movements. She's been troubled for 2 years and the discomfort is getting worse despite using regular analgesics. What do you think is the diagnosis?
So diagnosis sounds like it's basal thumb arthritis or first CMCJ arthritis. Looking at these radiographs, they look like PA radiographs of the base of the thumb joint. I can see large osteophyte sclerosis, loss of joint space, and some cysts affecting the first CMCJ, and as well as sclerosis and quite bad arthritis affecting the scaphotrapezial joint as well. So it is pantrapezial arthritis, I'd say Eaton grade 4, and there's some dorsal subluxation of the CMC joint, and there's also some hyperextension at the MCP joint of the thumb.
What treatment options do you think there are for this?
Treatment options, as always, we start with some conservative management, and the first options are oral non-steroidal and anti-inflammatory drugs, or even topical splinting and hand therapy, and a trial of this might improve symptoms.
What sort of splints would you provide for this condition?
Just a thumb spiker, and it could be used at various periods at night sometimes. I would say for arthritis at this level, grade 4, splits and NSAIDs might not work as well, especially since she's had worsening symptoms and she's tried analgesia according to the history. The next step up in intervention is steroid injections. And with steroid injections, I'd say they work better for grade 2 to grade 3 and mild arthritis when the main predominant factor is synovitis.
So you just told me about eating grade 4. Can you tell me about stage 1, 2 and 3?
So stage 1, there's predominantly some synovitis and some loosening of the ligaments, and you get some joint space widening, and there's no osteophyte formation or anything like that. In stage 2, there's some osteophytes, but they're less than 2 millimeters, and there's some joint space narrowing. In stage 3, there's large osteophytes, so more than 2 millimeters, and significant joint space narrowing. And then stage 4, you get pantrapezial arthritis like this.
So you don't think this patient would be a candidate for a steroid injection?
If she was a poor surgical candidate, I'd say steroid injection is an option. There's a paper by Swindles in 2010 which shows that even grade 4 arthritis, they did have good effect from steroid injection, although the numbers were quite small. In fact, they showed they had better relief from pain compared to other stages, but most other literature would say that grade 2 to 3 would be more appropriate for steroid injections.
So in this particular case, you decide to offer a surgical solution for this. What treatment options would you provide?
Treatment options surgically for this, I'd say the most practical treatment would be a trapeziectomy with ligament reconstruction, and we probably have to address the MP joint hyperextension at the same time.
So just to break that down, what do you mean by ligament reconstruction, and why would you do that?
So a trapeziectomy alone can be sufficient based on the current evidence. Some people would elect to use a tendon interposition or ligament reconstruction or both, and that can be done using an FCR tendon or an APL tendon, or even a palmaris graft just rolled up and used as an interposition. And this is usually used to stabilize the thumb metacarpal and prevents future subsidence of the metacarpal and prevent impingement on the scaphoid. Also just during pinch and grip procedures just to stabilize the thumb.
You mentioned that you'd have to address the thumb hyperextension, the Mcpj. What would you do for that?
So the thumb Mcpj, I would say it depends on the degree of hyperextension of the thumb. I get the patient to actually do pinch maneuvers and grip maneuvers to see how much hyperextension, how unstable the thumb MCP is. Also, if there's arthritis in the thumb. So if there's just about 10 degrees hyperextension, we could just stabilize it with a K-wire and see how things go with the trapeziectomy as well. If there's a bit more hyperextension, then I would say she would need a volar capsulodesis or even a sesamoidesis with more than 30 to 40 degrees hyperextension. And if there's arthritis as well, then I'd say an MCP fusion would be probably the best option.
So why does the MCPJ hyperextend like this?
So when you have arthritis in the base of the thumb, and pantrapezial arthritis is like this as well, you can see the CMC joint subluxes dorsally, and then you get adduction, adduction of the thumb metacarpal. So in order to compensate for that, there's a Z deformity, and the MCP joint hyperextend to make up for the adduction.
Okay.
In order to get the span that you need.
So you suggested that a trapeziectomy with a ligament reconstructive procedure is your preferred option. We'll come on to that in a moment. Are you aware of any other procedures that are offered for this condition?
Yes, so you could do an arthroplasty for this condition. You could do just tendon interposition, trapeziectomy alone, tendon interposition. You could do double interposition. You could do an arthroplasty, and you could
Okay, that's absolutely fine. Right. What I'd like you to do, this is a patient who you're going to be offering a trapeziectomy on. What I'd like you to do is just talk to them and explain what you're going to do and what those risks of surgery are going to be and what they can expect in the post-operative course.
And so we're going to perform a trapezoidectomy on you, where we're going to remove the bone that the base of your thumb is resting on. Okay, it will involve a scar just going across the back of your thumb here, and the section down. You do have tendons and nerves in the area which are at risk of getting damaged. We're obviously very careful when we do it, but if there is damage to that, we do repair it, and we can get onto that if that's a problem. We go down, we take the bone out, and what we do is we use a bit of tendon just to stabilize everything for you. Post-operatively, what would happen is your wound would be closed with absorbable sutures, and based on this, we will check your wound in a week's time. You will also have a cast on. We leave this cast on, especially if we use a tendon to stabilize the joint. We leave it on for about 4 weeks at least. We then take the cast off and mobilize you with some hand therapy, give you some exercises to do. You will feel the pain actually probably get worse over the first 48 to 72 hours, and then pain will gradually get better, but you find your arthritic pain improve over the next few weeks, but you get post-operative pain, which can actually take a long time to get better, and you'll find your strength and your pain improving, your strength improving. It will be quite protracted. It can be up to 3 to 6 months before you actually see good improvement. Your strength will continue to improve up to about a year.
Can I ask you to just now have a look at where you would make your incision? Can you just talk and mark the relative or relevant surface markings of those structures you've discussed? And,
so I would prefer to do a dorsal radial incision, and the first thing I would do is mark out the CMC joint. So we've got thumb metacarpal there, and mark out the CMC joint, I think it is. And then we've got some relevant structures to watch out for. So you have the superficial radial nerve, which would course along the radial side, and then it splits into a branch going to the thumb, and you've got a branch going to the index finger as well, so that will be in the way. We also have the first dorsal compartment, so the APL and the EPL tendons that go across there.
do you mean the EPL?
APL and EPB tendons here, and the EPL tendon there. And then you have your radial artery, which comes on the volar side here, and it courses on a volar to dorsal direction across the snuff box again, and goes through the two heads of the adductor pollicis. And there's also a little volar carpal branch which goes there. The incision I would make is on the just parallel to the first dorsal compartment, about 4.5 centimeters or so across the CMC joint, going down in a straight line.
And you mentioned that you do an LRTI. What's your preferred tendon for your ligament reconstruction?
So LRTI is usually done with the FCR. You can use an APL as well.
Would you show me where you make your incisions for the FCR harvest?
So for the FCR harvest, if I was doing an FCR, I might actually use a Wagner incision, and then I would do an incision between the glabrous and non-glabrous skin, stopping at on the border of the FCR. And the FCR tendon, I'd get the patient to extend the wrist, and you can mark the FCR tendon down there. And then I'd do a transverse incision there. If I was doing a dorsal incision and not there, I'd do an extra transverse incision there, about 1 centimeter. And then at the muscular tendons junction, another transverse incision. Use a tendon stripper or a tendon passer to harvest half the tendon. I would take the ulnar half of the tendon and then feed it across. I do prefer to use the APL as a suspensionoplasty as opposed to a ligament reconstruction and interposition nowadays.
Okay, thank you. So if you've undertaken your surgical procedure, you've done a trapezium excision and an APL suspensoplasty. The patient's been in plaster, come out of plaster, starting to rehabilitate, and maybe 6 months down the line they're starting to get pain again at the site of surgery. What are you thinking of in terms of the cause of this pain?
So the cause of pain after a trapeziectomy could be during the operation. Ideally, I would have inspected the base of the second metacarpal and the trapezoid joint and the scaphoid joint. The the scaphotrapezial joint as well. So I would say persistent pain would be an unaddressed scaphotrapezial arthritis. That could be one of the causes of pain. Another cause of pain could be injury to the superficial branch of the radial nerve. Could be unaddressed MCP hyperextension, so you can get late collapse of the MCP. That could be a cause of pain.
How do you deal with that?
In that case, if the MCP, if it's a late collapse of the MCP, you then have to address the MCP joint and go through the options that I talked about.
In a simple trapeziectomy, and the patient comes back 3 months after surgery. They've been out of a splint and they're starting to complain of pain at the site of surgery. Are there any conditions that can cause this? What would you be thinking about?
So the first thing I'm thinking about is actual arthrogenic injury. So injury to the superficial branch of the radial nerve during the procedure. That could be a cause of pain. The other cause of pain could be unaddressed arthritis, so pantrapezial arthritis, so arthritis at the scaphotrapezoid joint, the ST joint that was present, and you just took the trapezium out. That arthritis could still cause persisting pain. Another cause of pain would be hyperextension at the MCP joint that wasn't addressed. And you can get late painful collapse and instability of this joint. Other causes of pain can be things like complex regional pain syndrome and damage to other structures in the area.
So just to ask you about a couple of those, you mentioned about residual pain at the scaphotrapezoidal articulation. So how would you address that if you felt that was the feature of the pain postoperatively?
If I noticed some arthritis there during the operation, you could do a distal fold scaphoid excision, or you could do a proper 1/3 of trapezoid excision as well. If it was post-operatively and I found that was a problem and it was something that needed further surgery, we can then go in and actually excise the scaphotrapezial joint and then use tendon interposition.
Okay. What about for the McPj hyperextension, if you felt that was the source of the pain? What are the treatment options?
So for McPj hyperextension, if that was the source of the pain, then it again depends on the degree of instability and pain and hyperextension at the MCP. For just mild hyperextension and volar capsulodesis would be treatment option. And for more severe ones with arthritic MCP joints as well, I'd say a fusion in about 20-25 degrees would be my preferred option.
And so that will give you a scenario that the same patient has had a simple trapeziectomy and they've been fine for 3 years, but they then started to present with pain 3 years after a simple trapeziectomy. What conditions might you consider? You've already mentioned about migration. What do you think is underlying that problem?
So there's a problem with migration, subsidence of the metacarpal and impingement on the scaphoid, but I'm not sure of the clinical relevance of that. There is also a strong stabilizer of the scaphoid trapezial ligament, and I think there have been reports in literature that you can get some late flexion and dizzy deformities and carpal instability in the wrist after a trapeziectomy.
What about if the patient's just on gripping is getting symptomatic subluxation at the site of your previous excision?
So if it was a simple trapeziectomy, so there's no interposition or tep ligament reconstruction performed, it's just subluxation of the joint, so it needs addressing really instability at the CMCG.
And what sort of options have you got to treat instability, late instability there?
In that case, then I would do a ligament reconstruction or tendon interposition.
And could you talk me through that ligament reconstruction? What would you use in that scenario? So
in that scenario, I would use the flexor carpi radialis tendon, FCR tendon, harvest the tendon volarly, take the ulnar half of the tendon actually twists 180 degrees, and then you get a more one that's closer to the actual volar ligament, and then drill a hole through the metacarpal, feed it through, and then suture it through the metacarpal into the APL tendon as well. Wind it around the FCR and APL tendon.
Okay, thank you very much.
Thank you.
So that was the demonstration of a candidate as you would see in the exam. As I said, the difference between the real exam and this is that there will be two examiners, and they would normally swap halfway through, and one would be marking and the other would be asking the questions. So I'll show you the scoring grid for this particular station, if I can find it. Just 1 second. It's really strange when I do screen share. For some reason, it's not allowing me to. Oh yeah, I found it.
Just while you're doing that, Rajiv, I don't know whether everyone's managed to read the chat, but just to highlight some of the questions, Paul Malone queried about negative marking. There's no negative marking on the exam. There's another question about a bank of questions. There's no bank from the BSSH at all, but what people have used in the past is the ASSH past questions for their exams, which are floating around somewhere. I'm not sure if anyone specifically knows where they are, or you're all linked together on WhatsApp. People are doing their fellowships in hands, but they are out there to get hold of. Another thing stated was obviously with the American ones, there will be things such as elbow issues for baseball players, snake bites, and various other things that are not relevant. So take some of them with a pinch of salt, but generally they're not a bad level to start with.
So I have the scoring grid now. I'll just share that. So this is the scoring grid which was used for this skill station. So this is what the examiner will have. They'll have the candidate's name, examiner's name, date, and then the questions were divided into 4 groups here. So for the diagnosis and treatment, if you made a diagnosis and you suggested initial treatment, you would get 8 marks, which is split into 4 and 4. So you have to be asked in multiple categories, such as your core basic knowledge, core clinical knowledge, your higher order thinking, evidence of literature, practical skills, and patient and colleague communication. Now, practical skills here was actually drawing or marking out the incision, but some of the skill stations will be heavy on practical, in that it'll actually be a practical station. So here for the first part, you would have gained 8 marks, as in not 8 marks, you would have gained marks out of 8 for the diagnosis and treatment. The next set of questions were about the trapeziectomy advice, the incision, the consenting about the risks, discussion about LRTI, etc. So that was out of 16. So you would have had, say, that it's actually a little bit uneven, this particular skill station, in that normally you would have equal marks between half and half. So you've got a little bit more marks in the second set of questions. Third set of questions is about post-trapeziectomy pain, which you get 4 marks. Out of 4 marks, you can score in that. The last one are about the options for a painful instability, which is again out of 4. So it's a total of 32, and it's sort of split into 4 mark, into 4 marks for the various bits you can get asked. So that's the scoring grid.
Okay, was there anything else you want to mention?
Yeah, no, I think that's it actually. That was the video and the grid. Any other, if any questions, they can of course ask regarding that.
Okay. If anyone has any questions, you can pop it on the chat or just shout out now. Just for clarity, so all the examiners are going to come back at 1:30, please. All the delegates, if you can log back on at 1:45, you should end up not in this main room. You'll end up in rooms that have already been allotted to you, which are your Viva rooms. And you'll stay in that room, and the consultants Viving you will rotate. And you won't go back into the main room until all the side rooms shut down. You'll be automatically dragged into the central room. There will be some 10-15 minutes where you're in those rooms, and if you want to network there, figure out who's going to be vivaed and in what order you want vivering, just so it speeds things up when we come in. That'd be ideal. And then we will join you about 5 to 2 and kick off with the vivers. So any questions before we break for lunch? No, you don't. Ruth, can you clarify?
No, don't worry about logging out. Just stay online, and I'll sort the rooms out while you're away having lunch.
Thank you, but just don't be worried if when you come back from lunch that you're not in a big group. You're in a smaller group because you will have been pushed into the rooms.
Don't get shocked. And if you do want to log out and log back in again, that's fine. I'll pick you up, but just wait in the waiting room for me to take note.
Okay. Otherwise, have a nice lunch. Don't forget to mute if you're going to have your lunch.
Just one point, Mark. Actually, some people have volunteered to be Viva, others haven't. So my suggestion to everyone is to try and do the Vivas, because this is an opportunity before the exam to have a feel of how the skill stations are. So I'm hoping that there will be more people wanting to do the Vivas for the afternoon.